ठीक है. Okay, so let's start with the endocrine surgery. The first is the type of the discharge. Okay, let me just close this one. Yeah, you can see this. Let me know if it's totally visible. The first the question they can ask about the type of the nipple discharge. So this table is very important. Okay, they can ask you as an MCQ like in a match the following way. So suppose the milky white discharge is seen in galactorrhea when there is an increase in the prolactin level in the body, also in the hypothyroidism and some type of the antipsychotic drugs. Okay. Now serous, clear or the straw colored discharge. The most common is the fibrocystic disease. Okay, here the most common is the fibrocystic disease. This is the most common. Blood or the bloody stained discharge. Intraductal papilloma is the most common. Other are the carcinoma of the breast and the duct ectasia. Okay. Greenish, dirty, white or the thick discharge most commonly seen in the duct ectasia. Purulent or the yellow discharge, breast abscess or the infections, brown or the black, old blood, fibrocystic changes, watery and the thin, duct papilloma or the early carcinoma, greenish black is a duct ectasia. Okay, so remember this one. This table is very important. The type of the discharges and the causes of the nipple discharge. Okay. Now let's move to the what are the investigation. Now suppose a patient comes to you for the nipple discharges. So what are the first investigation you will do? Okay, the first is your mammography. Okay, the mammography is mostly for the screening, but it can be used for the if there is some suspicious lesions. If there is some suspicious lesion, then you can see in the mammography. Okay, now the cytological examination. The most common is the cytological examination is done to identify if there is any malignant cells are present or not. Okay, for this ductography is used. Okay, now ये याद रखना ductography is not recommended for the discharge from the multiple duct, bilateral discharges or the lactating women. Okay, otherwise the most common primary investigation for the ductography is the nipple discharges. Okay, what is the primary indication for the ductography? That is any type of the nipple discharges. But if the discharges is from the multiple duct and in the lactating woman, then it should not be recommended. Okay. Okay. Other than the third is the ultrasonography. USG, it may also show some presence of underlying mass is present or not. And the final diagnosis is done through the biopsy by the histopathological examination. Now, suppose it is a duct, so you have to do the microdectomy. Okay, microdectomy means excision of this duct and then histopathology, or you have to do the biopsy. Okay, or any underlying mass is present or not, you have to remove the duct and to see if any underlying mass is present, then you have to take the tissue cells and have to go with the biopsies. Okay, so these are the some of the most common investigation for the nipple discharges. Now first is mammography. This is usually done to know if there is a suspicious underlying mass is present or not. Mammography is best for the screening test, usually done after the 35 years of age. Okay, now the primary indication for the nipple, what is, if they ask you the question, what is the primary indication for the ductography? Your answer will be the nipple discharges. Okay. Okay, now come to the, what are the risk factor for the breast cancer? So this is a basically mnemonic of this: benign lady care. Okay, B for the, if there is a BRCA mutation, both BRCA1 and the BRCA2. Okay, if there is a BRCA mutation, benign breast disease may convert it into the malignant in the later stage. Early, E for the early menarche, N for the nulliparity, I. Increased age, G for the genetic family history, L for the late menopause. Alcohol abuse, D for the dense breast tissues, diet high in fat. Y for the years of estrogen exposure if the patient is on hormonal replacement therapy. 1 minute. Yes. So, dense breast tissues, years of estrogen exposure, cancer histories. Okay. A for the one type of ethnicity, I think a Jewish ethnicity. R for if the radiation exposure from the childhood. E for the exogenous estrogen. Oral contraceptive pills. Remember, there is an here not only it is written that only the estrogen and the if the patient is only taking the estrogen only, okay, it is not going to increase the risk of the breast cancer. But if it is in with estrogen and the progesterone, then it increases the risk of the breast cancer. And D for the obesity and the diabetes. Okay, so this is the mnemonic. Isko yaad rakhna. What is the mnemonic for the breast cancer? So it is easy for you to remember. Okay. Other thing is that smoking and the OCP does not increase the risk of the breast cancer, especially if it is an estrogen and the progesterone pill. Then it increases only estrogen, does not basically increases the risk of the breast cancer. Okay. Now there are the other, for example, age and gender. Most commonly the age, if it is more than 40 years of age, most common site is your upper outer quadrant. Okay, 60% of most the breast cancer are seen in the upper outer quadrant. Okay, now what is the most common presentation? How the breast cancer will come to you? There is a sudden increase. The first is that there is a sudden increase in the size of the tumor. Sudden increase. पहले उतना ज्यादा नहीं था, अचानक से it started to increase since 1 year. Okay, so this is the previous slide. Okay, and these are, ये ना जितने सारे अगर मैं क्यों डाल रही हूँ, these are basically MCQ based. Okay, most common women, the age of 40 years, most common in the upper outer quadrant. Okay, lump as a most common presentation, hard irregular non-tender mass, usually fixed to skin or the underlining tissues. Okay, I'm going slow then. Okay, lump is the most common presentation. Okay, the first you will see that a lump will be very much hard. It is irregular and non-tender. So it is basically a painless mass. For example, a patient comes to you, she is more than like 50 years of age, and she was telling you, I had this breast tumor since when I was in the age of 25. It was there, but suddenly since 1 year, after my stoppage of menstruation, it started to increase suddenly in a 1 to 2 year, and now it has become harder. Okay, so this is one of the feature of your you can think it can be a reason for the or risk factor for the CA. Okay, so there is a hard irregular mass usually fixed to the skin or the underlying tissues. Usually what happens if it is in fibroadenoma, it is movable. It is movable, but if it is in not fibroadenoma, if it is in tumor, I mean if it is harder, it is usually fixed. Then it is might be a case of a breast cancer. Okay, usually painless, skin changes, dimpling and puckering due to fibrosis, pulling of the Cooper's ligament, orange peel appearance from the lymphatic obstruction, ulceration in the advanced cases. In nipple, what we have seen the changes, there is a retraction or inversion, bloody or the serous discharge. If there is an eczema, Paget diseases. Areola, you will show eczema, crusting or the retraction. Fixity, always it fixed to the skin or the underlying tissue, fixed to the pectoralis major muscles or the chest wall. Axillary tail involvement, that is lump may or there is a lymph node swelling in the axilla. Lump may extend into the axilla. Okay. So lymph node involvement, it will be firm, hard, non-tender and matted nodes. Okay. And also the supraclavicular and the internal mammary group of the lymph node in the advanced cases. Okay, so these are the some of the common feature of the symptoms indicating of the breast cancer. Okay, so most common metastasis in the lungs. The patient will complain of cough and breathlessness. If the metastasis to the bone, so there may be back pain and some pathological fracture. If it is in the liver, then there may be a hepatomegaly and the jaundice. Okay. Okay, so this is the previous slide. तो just click the, आपको लिखने की जरूरत नहीं है. You can screenshot also. लिखने में if it is it's involving a time only, so better click the picture and then we go to the next slide. Okay. Okay. Now, so these are the late features. If there is a metastasis of the breast tumor into the other organ, so these are the clinic. If it is in the lungs, obviously there is a cough and breathlessness. If there is a bone, there is a back pain, pathological fracture. There is one of the thing in the bones. The most common is in the lumbar vertebra. Okay, LV means your lumbar vertebra. Then the femur. Then the thoracic vertebra. Then the ribs and the skull. Okay, so ये याद रखना, lumbar vertebra, femur, TV is your thoracic vertebra, ribs and the skull. So most common metastasis in bone in the lumbar vertebra, followed by the femur, then thoracic vertebra, then ribs and then the skull. So ये याद रखना, this is very important. Okay. Okay. So another thing, yes, if they ask you what is the most common cancer uh, of women in India, the most common cancer in women in India, then it is your CA cervix. If they ask you what is the most common cancer women in the worldwide, then the most common cancer in the women in the world answer will be carcinoma of the breast. Okay, so this can be one of the MCQ, one-liner MCQ. Okay. Now, what is triple assessment test? Okay, ये भी पूछ सकता है. What is triple assessment test? So, evaluation of the breast. Now, a patient comes to you with all the features of the breast cancer. There is an hardness of the tumor. There is a nipple discharges, bloody. There is a retraction of the nipple. So, what are the tests whenever you see this type of the patient in your clinic? The first will be the physical examination. Okay, so this physical examination along with the imaging will be either ultrasonography or the mammography. Okay, ultrasonography or the mammography. Okay, the needle biopsy, that is FNAC, or the true cut biopsy. Okay, you have to take the tissue and then you have to go for the biopsy. So this three together is known as your triple assessment test. Okay, and remember one thing: if you go with the imaging, if the woman is less than 35 years, you have to choose the ultrasonography because it dense tissues in the breast. Okay, and if the woman is more than 35, your investigation of the choice will be mammography. Okay, I'm going too fast. Okay, just wait for a few minutes. Let me finish this one. Okay, and if it is uncertain cases, in sometimes you have to do the both ultrasonography and the mammography. Special cases, you have to go with the MRI if there is an implant. Sometimes they can ask you whenever there is an implant, what investigation should you use? We should use the MRI breast. So this is one of the very important multiples like MCQ they can ask. Okay, breast lump fibroadenoma, it will be a well-defined smooth mass. If it is malignant, it will be irregular. There will be a microcalcification and the speculated irregular uh, margins. Okay, so this is for you the last slide. Dr. Saroj, are you asking for this one? Triple assessment?
Yes, ma'am.
Okay. Okay, so shall we move into the next slide now?
Yes, ma'am.
Okay. So this is, you can click the picture. Now, to confirm the catastrophic lesion, whether it is your benign or malignant, after going into the uh, clinical examination, we will do the ultrasonography or the mammography, depend upon the age. And if the breast is an implant, then the MRI breast should be done. And at last, we have to type of the breast cancer, we should do the biopsy, okay, FNAC, okay, or the true cut biopsy. Okay. Uh, okay. Now let's move to the next part about your what is the full form of the BIRADS. It has been asked in so many times, not only in the AIPG but also in the UPSC examination. Okay, so इसका याद रखना BIRADS का full form, Breast Imaging Reporting and Data System. Okay, developed by the American College of the Radiology to standardize the breast imaging reports. Okay, so these are the category of the BIRADS. One, incomplete, that means more, zero. If the category is zero, incomplete assessment, they need a more evaluation. If it is in the category 1, that means negative. If the BIRADS is in the category 2, it can be a benign cyst. Whenever you do the ultrasonography and the mammography, you will see in the report it has written that BIRADS 1, BIRADS 2 or the BIRADS 3. Okay, इस तरह से आपको देखने को लिखेगा if you see the reports of the mammography reports or the ultrasonography reports of the breast. Okay, the 3 will be probably benign. Next step will be the 6-month follow-up. 4, it can be a suspicious lesions, may or may not be, so biopsy is advised. 5 is highly suggestive of malignancy and the biopsy proven cancer is in the category 6. Okay, so ये भी याद रखो, maybe they can ask you with the questions. Okay. Let me see another thing. Chalo. Let's move to the pattern of the calcification of the breast disease. This pattern is also very important for your AIPGT examination. Popcorn calcification in the mammography, it is seen in the involuting or in the fibroadenoma. okay, in a fibroadenoma. If it is in teacup or rim calcification, it is seen in the cyst or the fibrocystic diseases. Vascular calcification seen in the old age diabetes, hypertension, eggshell rim calcification seen in the fat necrosis, dystrophic calcification in fat necrosis, old trauma. Okay. So this is very important according to the breast, that is a popcorn calcification seen in the fibroadenoma. Okay. Eggshell in the fat necrosis or the rim calcification is seen in the fat necrosis. Okay. So let's move into the next part of the slide. Shall I move? Okay. Let's move then to the next slide. So these are basically, if it is in pattern is popcorn, like calcification, it is a benign tumor. Okay. Now these are the suspicious malignant calcification. Occur in examination, if it is written, it is in pattern will be a fine linear, pleomorphic, fine granular or the clustered. Okay. So this can denote the carcinoma. Okay. सजेस्टिव डिजीज इतना याद रखना नहीं है, डीआईसी है और इन्वेसिव कार्सिनोमा है. जस्ट remember this: fine, irregular, clustered, or the linear branches suggest carcinoma. So in the examination, or in the question, they can ask you what type of the lesion is this? Is it benign lesions or is it fibroadenoma? It is your ductal cell carcinoma or the breast cyst? Anything they can ask. So you have to remember from this: if it is in fine, irregular, clustered, or linear branching, it suggests your carcinoma. Okay. And if it is your coarse, round, regular, scattered, then it can be a benign calcification. So this is very important: coarse, round, regular. Okay. And this is your fine, irregular, clustered, or the linear branching, suggestive of the breast carcinoma. Okay. Now come to the, what are the common lymph node metastases? So the lymph node metastasis, the common is your axillary group of lymph nodes. I'm writing it here. The most common, the metastasis in the axillary group of lymph node, more than 75% of the cases. And the second is your internal mammary group of the lymph nodes. Internal mammary group of lymph nodes. Okay. Yes. So itna yaad rakhna, the most common 75% of the cases, the lymph node which is involved is the axilla and followed by the internal mammary group of the lymph nodes. What are the complications of the mastectomy? The most common complication is seroma. Okay. So second is your, if there is an, after surgery, if there is some wound infections due to the fat necrosis, there may be an injury of the thoracic nerve. If there is an injury of the thoracic nerve, there is an palsy or the paralysis of the serratus anterior muscles, which resulting in the winged scapula. Okay. So injury of the thoracic nerve resulting into the winged scapula. Okay. Other than this, there is a lymph edema, injury to the thoracodorsal nerve. Okay. These are the things. So most common is your seroma, then the wound infections. Sometimes a patient may also complain of post-mastectomy pain. Okay. This post-mastectomy pain is also seen in the phantom pain. If you see in our drug in Allen's keynote, Allium-CEPA, it is written that neuralgia after the amputation. Okay, so we can use in this case also. That is, a patient may complain of a pain in the breast, in the axilla, in the upper arm. Okay, even after the removal of the total mastectomy, even after the removal of the breast tissues and their collateral branches, sometimes the patient may complain of pain in that part, which is radiating. Okay, so this is known as your phantom pain or the pain mastectomy, post-mastectomy pain. Okay, just go through this drug Allium-CEPA. एक बार देख लेना from the Allen's keynote. The reason one drug is Allium-CEPA और एक भी drug था which is not I can't remember this right now. There is written that is pain after the amputation. Okay. Let's move to the another part. Yeah. If they can ask you, what do you mean by the triple negative breast cancer? What is triple negative breast cancer? Okay. So whenever the oncologist, whenever they do the treatment of the breast cancer, they require some type of the chemotherapy. Sometimes it is your estrogen receptors types, progesterone receptors, or the human epidermal growth factor receptors. In triple negative breast cancer, these three receptors are absent. Okay, this is known as your HER negative. Sorry, HER positive. Okay, that means HER means your human epidermal growth factors. Okay, so this three together, if it is absent, then it is known as your triple negative breast cancer. That is, the cancer cell do not grow in response to the estrogen. So if there is an estrogen-based cancer breast tissues, then what they do, they will give some type of the estrogens or some type of the treatment which inhibit this progress. Okay. In some breast cancer, these three receptors are usually absent. And this type of the breast cancer are very hard to treat for the oncologist. Okay, the TNBC lacks three receptors. So certain targeted therapies like hormone therapies or HER targeted therapy won't work. ठीक है, इतना याद रखने की जरूरत नहीं है for our MCQ. It is only for your knowledge. Okay, so remember this. What do you mean by the triple negative breast cancer? Now come to the Paget disease. Paget disease of the nipple. What is it? Basically, it is an chronic eczematous condition of the nipple. Okay, from the picture, you can make it out. What is that? There is an eczema just around the nipple and with the discharge of some like fluid, which is called as a weeping lesion, ulcerated weeping lesions. It is usually unilateral, usually affects the one breast. Eczema-like changes with redness, scaling, or the crusting, itching, or burning sensation. Nipple discharges, often serous or the bloody. Nipple retraction in some cases, probably underlining the mass if massive cancer is present. So if the affected part, if you see there is an hard growth, okay, so it can be or may not be a feature of your breast cancer. Okay, so it's very near all the Paget disease of the nipple breast cancer. No, it is only about 95% of the cases of the Paget disease are they're having underlying breast like mass, which is a cancer. Okay, so underlying breast mass. Paget disease may or may not be accompanied by mass. Okay, and invasive, and if it is accompanied by mass, and that mass may or may not do the cancer. But as most of the cases, more than 95% of the cases, Paget disease in the nipple, they are positive in the CA breast. Okay, so there is a nipple retraction and some underlining mass. Okay, so what you will do, the first you will go with the complete mammography. if the age is more than 35 years of age, along with the biopsy. Okay, biopsy. Okay, and these are the some of the diseases of the facial disease of the nipple. Now move to the next part about fibroadenoma. Okay, it is the most common benign tumor of the female breast. The age will be 15 to 30 years of age. It is also known as breast mouse. All the fibroadenoma, they are basically dependent to the estrogens. Okay, so they are increased sensitivity to that of the estrogen. So this will be a painless. Sometimes there is a pain, but most of them there are the painless, slow growing mass, which is movable, which is known as your breast mouse. Okay, so this is all about your fibroadenoma. Okay, let's move. Now, am I going too fast? It is okay. Okay, let's move to the Mondor's disease. So what is Mondor's disease? It is also called as, this is known as Mondor's cord, which is called as superficial thrombophlebitis of the chest wall. So basically, superficial thrombophlebitis of the anterior chest wall. Sometimes the patient may complain of acute pain, or sometimes it is your painless. Okay, so there isn't some acute pain in the anterior aspect of the chest wall. Okay, so these are benign and the self-limited. Okay, so this is called your Mondor's diseases. Okay. There is another disease which is called as a breast abscess. So in the breast abscess, typically seen in staphylococcal infections, the affected breast, there will be a tenderness. There is a tenderness, pain is there. The affected area is hot. Okay, so there is an hyperthermia. Just all the features of the belladonna, इतना याद रखना, जितने सारे features है ना belladonna के, reddish discoloration होगा, the breast tissues थोड़े बहुत hard होंगे, थोड़ा बहुत गर्म होगा. Okay, so these are the clinical features of the breast abscess. Okay, and they are related to lactation, occurs within the first few weeks of breastfeeding. They occurs within first few weeks of breastfeeding. Chaliye, so this is all about your breast abscess. So anybody have any questions or any slide missed, so that I can move to that slide? Achha, there is another thing just wanted to tell you. Emasia. Emasia means absence of the breast, one or the both side. This is known as your emasia. Okay. Sometimes along with the breast, there is an absence of the pectoralis majors muscles. Sometimes there is an absence of pectoralis majors muscle. Then this is known as the Poland syndrome. Okay. So this is all about your breast endocrine surgery, the breast chapter, breast. Okay. Okay. Now let's move to the another part. This is called yours thyroglossal or the thyroid, the thyroglossal tract or the thyroglossal fistula. Just give me 2 minutes. Okay. So if you see this diagram, so this is your foramen cecum, and basically this is a pathway of the thyroid gland. Okay. So this is known as your thyroglossal duct, and from this thyroglossal duct, the thyroid gland started to descend down. Okay, it started developing from the oropharynx of the foramen cecum of the fetus, and then it descended down, and it's finally positioned in the anterior portion of the neck, taking part through the tongues, and then there is an hyoid bone, the neck muscle, and then it is basically situated in the anterior portion of the throat. Okay, now after that, now this thyroglossal duct, it basically uh, atrophy, or you can say that this duct normally atrophies or closes off before the birth. Okay, but if it can remain in some people, then this resulting into the thyroglossal duct. So what do you mean by the thyroglossal duct? That means when the thyroglossal tract fails to fuse or fails to atrophy, then it is called as a thyroglossal duct cyst. Okay, persistent thyroglossal duct, and when there is a formation of some type of the fluid in the thyroglossal duct, they resulting into the thyroglossal cyst. Okay, so what are the clinical features of the thyroglossal cyst? So number one, its most common site will be the most common site will be the subhyoid. The thyroglossal cyst, the most common site will be the subhyoid. There is an other common site, that is floor of the mouth, and then there is an just here also beneath the foramen cecum, beneath the foramen cecum, also in the suprahyoid bone. Okay, also here in the suprahyoid bone. Okay, so most common is the subhyoid, and then there is another common site which is floor of the mouth, foramen cecum, that is beneath the foramen cecum and the subhyoid bone. The patient will complain of midline neck swelling, usually below the hyoid bone. And when he sallows, now suppose a patient comes to you with the sallowing in the small sallowing in the thyroid, not in the thyroid, just in the front portion of the throat, and you will ask the person to sallow, okay, or just to move out your tongue, like move and then insert your tongue inside, then you will see there is a movement of that cyst. Okay, so midline swelling of the neck and also the movement of the cyst on upward sallowing or the tongue protrusion. This is an important diagnostic sign for the thyroglossal cyst. Okay, usually the most common the patient, this is a basically congenital. Okay, the congenital swelling and the age of presentation will be the 15 between the 15 to 30 years of age. Okay, between the 15 to 30 years of age. So there is a midline neck swelling, and the swelling will move upward and downward on the protrusion of the tongue. So what are the complications you can see in the thyroglossal cyst? Either there will be formation of the recurrent infection, there is a formation of the thyroglossal fistula. So these are the complications. Fistula usually occur in the thyroglossal cyst after the operation. So thyroglossal fistula is always acquired, while the thyroglossal cyst is always congenital. Okay, it is always a congenital. Now, the thyroglossal cyst, they have more chance to develop the papillary carcinoma of the thyroid. इसको याद रखना, they have more chance to develop the papillary carcinoma of the thyroid. Okay, this is so thyroglossal. These are some of the questions. ये आ सकता है the most common side. What are the other side? They can ask you about the what are the clinical features. Okay, or they will present you a case of a thyroglossal cyst or the fistula, and then will ask you about to identify the what is the diagnosis of the disease. Okay. So sometimes there is if there is a sinus, there is a persistent discharge of some pus discharge from that affected cyst. Now come to the what do you mean by the Pemberton sign or your retrosternal goiter thyroid. Okay, so let's see what is retrosternal thyroid. If you see, this is the normal location of the thyroid. If the thyroid is located just below the opening of the thoracic cage, thyroid tissue is below the opening of the thoracic cage, then it is known as your retrosternal goiter. Other name is a substernal goiter, all other things. Okay, how will you find it? Obviously through the X-ray of the chest. Most common investigation is X-ray of the chest. Sometimes there is no symptoms. Usually they are asymptomatic, and it is accidentally diagnosed when a patient go with a routine clinical or checkup. Okay. So what are the common sign and symptoms of the retrosternal thyroid? So I'm writing it here. The common symptoms of the retrosternal thyroid. Okay. Now suppose if there is an swelling in this area, in the thyroid, okay? The most common symptom will be the what? Dyspnea. The most common symptom will dyspnea, okay? Also, if there is a dyspnea and if there is an thyroid, goiter, formation of the goiter in the substernal region of the thyroid gland, then obviously there is a dysphagia also. So difficulty in deglutition and the difficulty and the respiratory distress, sometimes with the cough and shortness of the or the stridor. Okay, and Pemberton sign is very much positive. Okay, what you will see that if there is a large retrosternal goiter, if it is present, it causes venous distension of the neck. And if you ask the patient, just take your hand above the head, there is a facial flushing. This is known as your Pemberton sign. So symptoms of the evidence of the facial congestion. Okay, it is done when you ask the patient to raise their arm. This is called your Pemberton sign. Okay, when the arms are raised, it is due to the when the retrosternal goiter they obstruct the external jugular vein. So Pemberton sign is seen in where? It is seen in the retrosternal goiter. Okay. So this is all about your retrosternal goiter. So these are some of the investigation. Number one, ultrasonography. or the X-ray of this. Then you have to go with the radionuclide scan assessment of the thyroid functions. So basically, what are for the investigation of the thyroid disorders. So if there is any enlargement of the thyroid, you have to go with the ultrasonography of the thyroid gland, okay? Or the radionuclide assessment of the thyroid functions. Most commonly, the isotopes which are used are 1I-131 and I-132 and I-123, okay? So to know the assessment of the thyroid, whether the hormones, they are whether the thyroid is working or not, for that we have to go with the radionuclide or the thyroid scan. Okay. Other is an hormone, that is T3, T4 and the TSH hormones. Now come to the acute suppurative thyroiditis. So usually this is acute. Okay. So acute suppurative thyroiditis, it is most commonly seen in the children. Okay, so this is one of the pointer, then that of the adult. So most commonly seen in the children, usually seen if there is an history of recent history of or the past history, the recent history of repeated upper respiratory tract infections, or there may be a recurrent ear infections, otitis media. Now, with the help of the lymphatic or the hematogenous spread or via the direct spread, it enters into the thyroid gland and causes inflammation of the thyroid gland, which resulting into the formation of the sinus fistulae or a thyroglossal type of fistula. Okay. So acute suppurative, one of the main causes, if there is a persistent or recurrent upper respiratory tract in children or otitis media, so infectious agent can spread into the thyroid gland via the hematogenous spread or the lymphatic spread. Sometimes is it also a result of penetrating trauma. Okay, so what you will see, there is a persistent discharge of some watery, most common presence of the piniform sinus, and this sinus is most commonly seen in the left side, and the consistent discharge of some watery discharges. Okay, so these are acute suppurative thyroiditis. Often, if there is a suppuration, there is some inflammation and infections, always you will see the feature of a fever, along with the small, tender goiter with the discharge of that person. Okay, there is an increase of the ESR and the WBC count. And FNAC, it will show your polymorphonuclear leukocytes. Okay, it will show a large number of the white blood cell, mostly the polymorphonuclear leukocytes. Okay, so acute suppurative thyroiditis, the common cause is upper respiratory tract infections or the otitis media. Once the infection via the blood or the lymphatic spreads enters into the thyroid gland, and they resulting into the piniform sinus or some type of the sinus. Another cause will be the penetrating trauma. Okay? So this is all about your acute suppurative thyroiditis. Okay, if I'm going too fast, please let me know in the chat box. I will slow my pace then. Okay? Hmm. Now come to the subacute thyroiditis or the decubital thyroiditis. So it is a self-limiting inflammatory disorder of the thyroid gland, usually followed by the viral infections. It is also the same thing. It is usually followed by the viral infection. There may be a history of a upper respiratory tract infection, just like suppurative. It has also history of the upper respiratory tract infections. And there is an strongly associated with the HLA-B35 haplotype G. Okay, so ये याद रखना. And the peak incidence will be 30 to 50 years. So acute hepatitis mostly in the children, but here it is in the adult 30 to 50 years of ages. Okay. So what are the clinical features? There is a history of viral infections, often follows an upper respiratory tract infection. The patient may complain of neck pain, painful tender swelling in the anterior neck, and this pain sometimes may radiate to the jaw, ear, and the occiput. Whenever there is an infection, viral infection, obviously there is a fever and the malaise. So these are both are the common symptoms after the history of any upper respiratory viral infections. Now, what are the clinical features you will see? Number one, this one, painful and the fever. Painful and the fever. Now, here, first there will be a sudden, suppose this is thyroid gland. When there is an infection, there is a sudden increase of the T3 and the T4 hormones. So you will see the persistence of some thyrotoxic symptom, that is palpitation, heat tolerance, anxiety, tremor, weight loss. So these are the symptoms of the transient when there is a sudden rapid increase of the T3 and the T4. Sudden increase of the T3 and the T4. Then afterward, after the hormone, suppose बहुत T3, T4 निकल गया, then the T3, T4 reduces. After hormone depletion, that is T3 and T4, there is a temporary hypothyroidism may occur. So after there is a feature of the hyperthyroidism, you will get the feature of a hypothyroidism. Okay. So there may be fatigue, cold intolerance, and the weight gain. Okay. Then there will be in the letter 1, there is a recovery phase. Okay. So recovery phase, usually complete recovery in week or month. After that, unlike suppurative thyroiditis, there is no abscess or the bacterial infections. Okay. And also there is an increase of the ESR. ESR is markedly elevated. And the T3, T4, TSH, they are, their result is elevated or decreases, depends upon the status of the subacute thyroiditis, or in which phase the subacute thyroiditis is presenting in your clinic. Okay. So this is your about subacute or the decubital thyroiditis. Okay. So if you have any doubt, you will go with the FNAC. For any doubt, whether it is benign, it can be malignant, what are the cells, the FNAC will be the diagnosis, and it will show the giant multinucleated cells. Okay. So this is all about your subacute thyroiditis. किसी को कुछ भी क्वेश्चंस है इसमें से? Then they will move to the Hashimoto disease. Any questions? Okay. I will try to finish the endocrine surgery by today. So I'm going a bit faster. Okay. So remember, these are the lab findings. इसको आप याद रख लो. Initially T3, T4, then TSH, and then later T3, T4 hypothyroid phase है. उसके बाद recovery phase, इसमें सब कुछ normal हो जाएगा. Okay. Radio uptake iron very low during thyrotoxic phase. due to the thyroid destruction and the not overproduction. Okay. So why there is an overproduction of the T3, T4? This overproduction is mainly due to severe, suddenly destruction of the thyroid tissue cells, and there is a rapid formation, or you can say that जितने सारे T3, T4 निकल के एक साथ थे वो सब बाहर निकल के. Okay, so there is now this thyrotoxic phase is due to the thyroid destruction, not from the overproduction. Okay. So these are the clinical lab finding of the subacute thyroiditis. What is radioactive iodine uptake test? It is a diagnostic test to assess, measure how much iodine the thyroid gland can absorb from the bloodstream, and they help to assess the thyroid function. Now come to the riedel thyroiditis. तो इसके लिए ना एक याद रखना न्यूमोनिक और rock hard, R for the rock hard, are for the very much rare in occurrence. Okay, and are for the whole thyroid gland is replaced by the fibrosis. So there is another name is your chronic fibrosing thyroiditis. That means fibrous tissues replaces the thyroid parenchyma. Okay, so this is riedel thyroiditis seen in the middle-aged woman. Woody, hard, fixed, painless thyroid swelling like a stone. Stony, hard swelling of the thyroid gland. Okay. If there is an fibrosis, if there is an enlargement with the fibrosis, if it affects the trachea, then it causes breathing difficulty. If it causes pressure in the esophagus, then also swallowing and breathing difficulties. Whenever this type of the fibrosis, fibrosed gland if enlarged and hard, if it pushes the recurrent laryngeal nerve, it causes hoarseness. Okay, so usually the third functions it decreases, so it causes a feature of a hypothyroidism. So patient may, because the whole thyroid gland, suppose this thyroid gland, and among the thyroid gland, these are the 4 parathyroid gland. So ये पूरा thyroid, पूरा जो gland है ना, along with the parathyroid gland, it get fibrosed. Okay. So what happened? The T3 and T4, which is coming out from this gland, it started to depress, it decreases. Okay, so there is a feature of, but the TSH is there. TSH, the body does not have any T3 and T4. So body is telling the anterior pituitary to secrete more hormone so that we can get more T3. So that is a T4. Okay. So here there is an increase in the TSH as a body, as anterior pituitary is secreting more TSH just to develop the more T3 and T4. Okay. So these are the compensatory mechanism of our body. But as it is get totally destruction of this thyroid gland, so there will be no increase in T3, T4. The patient will be see the clinical feature of the hypothyroidism, and sometimes with the hypoparathyroidism. Okay, we will come to the next part. What are the clinical feature of the hypoparathyroidism? Okay, the gland become woody and very much hard in nature. ठीक है, तो इस तरह से आपको याद रखो न्यूमोनिक फॉर द रिकॉल फॉर द riedel thyroiditis. That is rare, rock hard, invasive fibrosis, middle-aged female, dyspnea, dysphagia, hoarseness, endocrine failure, hypothyroidism, and the hypoparathyroidism भी इसमें लगा लो, and the lower radio uptake iron because of all the thyroid issues gets destructed, and it is a very long-standing disease. Okay. So this is all about your riedel thyroiditis. Okay. कौन सा स्लाइड ये वाला
Yes, ma'am.
Okay, just note it down. चलो. Now come to the Hashimoto thyroiditis, a very important MCQ topic. Okay, Hashi. So think about Hashi in this way: the mnemonic H for the hypo. Obviously, it is an autoimmune disease. Okay, why autoimmune disease? Will come to the letter. S for the gland becomes swollen. The gland become hard, and they are usually iodine related. The person who is taking iodine salt for a prolonged period of time, where there is plenty of iron, they also resulting in the Hashimoto thyroiditis. So there is an antibody. The antibody name will be the anti-TPO, that is thyroid peroxidase. Anti-TPO full form is your thyroid peroxidase. 95% of the TPO, anti-TPO is formed, anti-thyroid peroxidase. Antibodies are formed against this this enzyme, thyroid peroxidase. Okay, and the anti-thyroglobulin, which is about your 60%. Now, suppose just wanted to show you, this is your thyroid gland and this is parathyroid gland. Okay, and these are some receptors. Okay, यहाँ पर कुछ कुछ receptors हैं. Okay, इस receptors का एक नाम है thyroid peroxidase. Is one of the enzymes. It is present here. This enzyme will tell when the TSH is coming, this will tell the gland to produce T4 and T3. Okay. Now again, this enzyme, an antibody is formed. Okay. So this एक तो ये enzyme है, दूसरा है thyroglobulin or the anti-thyroglobulin and antibodies है. So one is a thyroid peroxidase enzyme, the other one is a thyroglobulin. Okay, protein. इसके अगेंस्ट भी एक एंटीबॉडीज डेवलप होती हैं. So because of there is an antibody against this type of the receptors, this type of the cells, is known as the Hashimoto thyroiditis. Usually in the middle-aged women, painless, firm, rubbery, and large thyroid gland. The features of all the features of the hypothyroidism you will get in the Hashimoto diseases. Okay. So I think you already know what are the features of hypothyroidism and the thyrotoxicosis. You will get to know from these medicines. So, इतना याद रखना, हाशी, हाइपो, ए, ऑटोइम्यून, कौन सा एंजाइम है, एंटी टीपीओ के अगेंस्ट और होता है तुम्हारा थायरोग्लोबुलिन. Okay, so most commonly in the anti-TPO antibodies. So, and if you go with the test me, there will be increase of TSH, T3, T4, which is a common feature of hypothyroidism. And whether to know what is Hashimoto or not, you have to go with the anti-TPO antibodies test. Okay? So these are the Hashimoto thyroiditis. Okay? 1 minute. Yeah. So this is a pathology. इसको भी याद रख लेना. The gland are mildly enlarged and the follicles are lined by Hürthle cell. This is important MCQs. They can ask in assertion and reasoning part. And the Hürthle cell changes takes place in this type of this Hashimoto thyroiditis. The normal thyroid follicular cell become large, pink, and the eosinophilic and the granular, do damage and the degeneration. Okay, so this is also very important MCQs. Hürthle cell एक तो मिलता है Hashimoto thyroiditis, which is most common. Others are the multinodular goiter and the follicular adenoma. Okay, चलो. So this is also very important. If they can ask you Hurther cell seen in which type of the diseases, most common in Hashimoto and the other two. Previous slide, yes. Sorry. Yeah. Graves' disease, or known as the toxic diffuse goiter. These are all the features of the clinical hyperthyroidism you will get in the Graves' diseases. So here the antibodies are against the thyroid stimulating hormones or thyroid stimulating receptors, not the hormones. Here the antibodies are against the TSH receptors. Most common, the age group will be 40 to 60 years of age. Most common age is 40 to 60 years. So these are the clinical features. There is a swelling or excessive perspirations, visions are like bulging eyes, and they are associated with HLA, E8, HLA, DR3, HLA, DQA10501. Okay, associated with this type of this genes. So these are the type: autoimmune hyperthyroidism, antibodies against the thyroid stimulating receptors or the immunoglobulin, seen in the young to middle aged women, and CC pneumonic, इसको याद रख लेना. ठीक है. Goiter, R for the rapid heartbeat, A for the autoimmune, TSI antibodies, V for the vision problems, exophthalmies, exophthalmos, E for the elevated metabolism, so weight loss, heat intolerance, too much perspiration, this one. Skin changes, peritibial myxedema, which is rare, and thickened on the shins. So these are the pneumonic. For ये pneumonic याद रखो, तो आपको ज़्यादा कुछ याद रखने की जरूरत नहीं है. Okay. और कुछ, let me see. हाँ. Other than this, now the Graves' disease, in hyperthyroidism, there may be a feature of amenorrhea. In female, sterility. Okay. When there is an excessive T3 and T4 hormone, so there will be an early bone maturation. Okay, there will be early bone maturation. So you can see the excessive growth of the bones. Okay, excessive growth, osteitis, bony growth. Okay, so excessive growth of the bone. So, and there is an increased GI frequency, that is bowel movement or diarrhea. If you read the metrometic of natrium mu and the Ellens or the iodine, you will get all the features of the Graves' disease. Natrium mu is usually seen in both the both the diarrhea and the constipation, but it is most suitably in the diarrhea state. Okay, so bowel movement is also, there is an increased frequency of the bowel movement and the diarrhea. Okay, so these are some clinical features of the Graves' diseases. Okay, so these are some of the lab findings क्योंकि थायराइड ग्लैंड सही है, एंटीबॉडीज अगेंस्ट द TSH रिसेप्टर्स है, सो यहाँ पर रेडियो एक्टिव आयोडाइन अपटेक इज इंक्रीजेस है। जहाँ पर थायराइड ग्लैंड डिक्रीज डिस्ट्रक्शन होगा, the RAUI absorption decreases, and जहाँ increases thyroid like T3 T4 activity is okay, thyroid gland is okay, there the high uptake of RAIU. Okay, so let's move to the carcinoma of the thyroid gland. ठीक है, ये करके we will finish the thyroid, फिर 5-10 मिनट का ब्रेक लेंगे and we will go with the parathyroid and the adrenal gland. Okay. So papillary carcinoma, these are the 4 most common type में है, that is papillary carcinoma. What is the most common type of the thyroid cancer? Your answer will be papillary carcinoma. So what are the important pointers of the papillary carcinoma? Most common thyroid malignancy, low dose of radiation exposure, thyroglossal cyst, and the Hashimoto thyroiditis. Remember, Hashimoto thyroiditis in the long run can lead to the papillary carcinoma. Okay. In the pathology, you will see the Sama bodies and the orphan eye nuclei. These are very important. बहुत बार पूछा गया है. ठीक है. This too. The pathology you will find in the papillary carcinoma. Okay. Spread by the lymphatic group of the lymph nodes. There is an spread is usually the hematogenous spread is less, but mostly in the lymphatic group from the lymph nodes. Okay. Metastasis most commonly in the lung, followed by the bone, liver, and the brain. Okay. Most commonly age group of the papillary carcinoma is 30 to 40 years of age. The patient will come to you with a painless, slow-growing tumor or the slow-growing painless mass in the anterior throat or the anterior neck. When the mass increases in size, then there will be a feature of dysphagia, dyspnea, all these things. Okay. Prognosis, local recurrence is common and it's excellent prognosis. Okay. Diagnosis by to the FNAC. It has excellent prognosis with 95% of the survival rate. So FNAC is the choice of like investigation of the choice. Now this is all about your papillary. It's the most common thyroid malignancy. Okay, so this is important. Now come to the follicular carcinoma of the thyroid. It is less common. It is about 10% of all the thyroid cancer. Most commonly in the iodine deficient area, seen in the among the 50 years of age. In follicular carcinoma of the thyroid, just like papillary carcinoma, we can know that from the FNAC we can distinguish, but we cannot do FNAC in the follicular carcinoma of the thyroid because FNAC cannot distinguish between the thyroid cancer and the adenoma of the thyroid gland. So one is follicular adenoma and the follicular carcinoma. We cannot do the FNAC because FNAC doesn't help to distinguish between the follicular carcinoma and the follicular adenoma. Lymph node involvement is rare, most commonly in the hematogenous spread. Okay, and if it is present, the most common will be the cervical group of lymph adenopathy. Most commonly is the hematogenous by the lungs and the bones. Bone metastases are the pulsatile. So these are the most common site of metastasis of the bone in follicular carcinoma: vertebra, ribs, pelvis, and the skull. Okay, V for the vertebra, R for the ribs, P for the pelvis, and the S for the skull. Okay. So here the वहां पर क्या था, papillary carcinoma, there is a slow growing tumor, but the follicular carcinoma, it is a rapid growing inside. A patient may be present of long standing goiter. Maybe he has having goiter for a long period of the time, but suddenly it started to increase in a year. Okay, so standing goiter suddenly started to increase, and there is a rapid increase in the signs. So we can think of follicular carcinoma of the thyroid. Okay. Now this is the third one, which is known as your medullary carcinoma of the thyroid. See, all the thyroid carcinoma, one is follicular from the follicular cell, the follicular carcinoma, okay, and the papillary cell from the thyroid carcinoma. But the medullary carcinoma, it is usually originated from the parafollicular cell. And we know that parafollicular cell produces calcitonin. So medullary carcinoma is not going to depend upon the T3, T4 and the TSH. Okay. So usually they arising from the parafollicular cell. This parafollicular cell secrete a large number of the calcitonin. Okay. They spread by the both lymphatic and the hematogenous group of the lymph node, and the most common spread in the liver. Does not respond to radioactive iodine. Why? Because the cancer is arises from the parafollicular cell, not the follicular cell from where the T3, T4 is generated. Okay, so parafollicular cell has, so it does not respond to any radioactive iodine. There is an elevated calcitonin level, CEA level, okay? And there is an amyloid stroma EC marker. So what are the markers? If the calcitonin raises, if the CEA level rises, and the amyloid stroma or the FNAC, okay? Calcitonin is raised in all the cases of the medullary carcinoma of the thyroid. So even when there is an increase of the calcitonin, MTC is not associated with the hypocalcemia. Okay. Remember this, there is no feature of the hypocalcemia. Okay. Associated with RET mutation oncogene, despite increase of the calcitonin, there is an normocalcemia, or there is no decrease of the calcium ion in the body. We know that. Okay. So this you should remember this one. Medullary carcinoma of the thyroid. Okay, let me see if anything I miss. Hello. So So another is your anaplastic carcinoma. It is an rarest, most aggressive form. 7 to 8 decade, rapid increase in the neck mass, severe pain, dysphagia, dyspnea, hoarseness, direct invasion, and the most common site metastasis is the lung. Okay. So the last part, what is the complication of the thyroidectomy? Number 1 is hemorrhage. Okay, due to the, if there is an injury of the slipping of the ligature on the superior thyroid artery, and if there is an bleeding from any type of these muscular arteries. So hematoma can also be formed after the immediate surgery if the healing does not take place in a normal way, the formation of the hematoma. Okay, I think I have written it here. Oh, sorry. So yeah, the hematoma. The second one is your, if the hematoma it increases in size, it causes what? It causes respiratory obstruction. Okay, it causes respiratory obstruction. There will be a recurrent laryngeal nerve paralysis. Laryngeal nerve paralysis. Recurrent laryngeal nerve paralysis can resulting into the dyspnea and the stridor. Okay. So this is all about your complication of the thyroidectomy. So ये दोनों बहुत important है. What is Wolff-Chaikoff effect and what is Joe-Bestow's effect? Okay. So Wolff-Chaikoff effect means your Wolff stops the flow of iodine. इतना याद रखना है. WOLFF, Wolff. Okay, stops the flow of the iodine. So within the thyroid gland, when there is an overload of the iodine, sudden large iodine intake, there is a limit thyroid hormone synthesis. Okay, so formation of T3, T4 stops temporarily. Feedback inhibition due to excessive iodine. So this is known as your Wolff-Chaikoff effect. All the feature of the hyperthyroidism you can see in this effect. This is the one. Another is your Joe-Bestow's effect, same thing, resulting in the hyperthyroidism. A patient is taking too much iodine and he will producing the symptoms of the hyperthyroidism. Okay. What do you mean by this Kephart trachea? Flattening of the trachea caused by the lateral compression of the swelling of the tumor, seen in the carcinoma of the thyroid, goiter, carcinoma of the larynx, and the thyroiditis. Okay. So this is all about your thyroid gland. 10 मिनट का ब्रेक लगते हैं और उसके बाद हम लोग पैराथायराइड एंड द एड्रिनल ग्लैंड शुरू करके खत्म कर देंगे. ठीक है. If you have any questions on this slide, let me know. Slide, okay. कौन सा slide? Just have a break for 10 minutes. इसके बाद में आती है. Okay. So let's have a break for 10 minutes. I will meet at 3:15 or 3:20, okay? Okay, let's start with the next part of parathyroid gland. Okay? Then, एक minute, huh? Yes. Multiple neuroendocrine neoplasia. Yeah. So multiple endocrine neoplasia, multiple endocrine organs is affected with the new growth. Okay. So there are basically MEN1, MEN2A, 2B. It is So another name of MEN3 and the another one is MEN4. ठीक है? So MEN इसमें से सबसे this three is very important. MEN1, 2 and 2B. Okay. So what are the tumor or the gland involved in the MEN1? Remember this diagram. One is pituitary adenoma, parathyroid hyperplasia, okay, and the pancreatic tumor. Okay. So these three organs are most commonly affected in the MEN1. Okay. Pituitary, parathyroid, and the pancreatic tumor. Whereas in the MEN2A, there is a parathyroid hyperplasia, medullary thyroid carcinoma, that means follicular cells, parafollicular cell is affected, okay, and the pherecytoma, that is adrenal gland is affected in MEN2A. In the MEN2B or the 3, there is a mucosal neuroma, small growth all over this mucous membrane in the body. Marfanoid body habitus or the Marfan's syndrome, okay, the Marfan's syndromes, medullary thyroid carcinoma, okay, common in both MEN2A to B, not in the MEN1, and the pherecytoma common in both 2A and 2B. Okay, so ये याद रखना. Along with this, megacolon. So this is very important. ठीक है? From यहाँ से कई questions आ जाते हैं. Only from this table. Okay. So MEN4. Here you will get the feature of hyperparathyroidism. Means the parathyroid gland is affected. Pituitary adenoma. So pituitary adenoma is there. Okay. Pancreatic tumor, pancreatic neuroendocrine tumor. Okay. So pancreatic tumor. So all the feature of MEN1 is the common with the MEN4. Okay. MEN1 is not having the mutation of MEN1 gene, is also known as MEN4. Okay. And along with this, so only the difference is there, what is written here in MEN1, they do not have the mutation of the gene of MEN1, but they do have the mutation of MEN4 gene. I don't know what is this, but yeah, the difference is between itna yaad rakhna. MEN1 and MEN4 both are all the endocrine tumors are equally affected, and MEN2 and 2B, these are the most common features. Both have medullary thyroid carcinoma, both have a pherecytoma. Okay. And in the cases, the gene is affected is your RET oncogene. RET oncogene. Here the gene is your MEN1 gene, multiple endocrine neoplasia 1 gene, the defect in the MEN1 gene. And here in the CDNIKIB gene. Okay, CDNKIB gene. Okay. And all of them are the autosomal dominant. MEN1, MEN2, MEN3, MEN4, all are autosomal dominant. Okay. Okay. Remember one thing, the MEN1 multiple endocrine neuroendocrine tumor 1, its other name is your Werner syndrome. Okay. If they ask you what is the most common abnormality in the MEN, सबसे most common abnormality in the endocrine abnormality in the MEN1, the answer will be your parathyroid hyperplasia. Most common endocrine abnormality is a parathyroid tumor or the parathyroid hyperplasia. So you will get all the clinical feature of the hyperparathyroidism. Okay. And we know that the parathyroid hormone, help in increases the secretion of the PT3 hormones, which causes increase of the calcium ion level in the body. So first, biochemical abnormality in MEN1 will be the hypercalcemia. Okay, this is the one. The second most endocrine MEN1, second most common endocrine abnormality in MEN1 is a pancreatic tumor. Okay, pancreatic neuroendocrine pancreatic neuroendocrine tumor. Okay, and the most common hormones which is secreted from the pancreatic tumor is pancreatic polypeptide. Okay, I'm writing here PP, which means a pancreatic polypeptide, followed by the gastrin. So there is a gastrinoma. All the features of the gastrinoma you can see in the multiple endocrine neoplasia, and also the insulin, followed by the insulin. The mnemonic will be PGI. Okay, the second most endocrine neuro abnormality is your pancreatic tumor. And these are the clinical features you will find in the pancreatic tumor. If there is an gastrinoma, the features of gastrinoma. If there is an insulinoma, the features of the insulinoma. If there is a pancreatic peptide, that is PP, basically the cell of the pancreas. So there will be a pancreatic peptide. So there is a first abnormality of the pancreatic hormone, which usually more secretes in the pancreatic tumor, is the pancreatic polypeptide. Okay, so these are the things, and let's see what are the clinical manifestation of the your primary hyperparathyroidism. Okay, so now suppose, for example, this is your thyroid gland and this is your parathyroid gland. Okay, the most common cause for the primary hyperparathyroidism is a tumor in the parathyroid gland. If they ask you what is the most common cause of the primary hyperparathyroidism, your answer will be the parathyroid adenoma. And they usually involve the which lobe of the parathyroid gland? So there are the 4 lobes, and basically the inferior parathyroid gland. These are most commonly affected. Okay. Yes, located in the inferior parathyroid gland. Okay. We know that the parathyroid hormone, whenever it helps in the release of the calcium ion in the body, if more the PTTH releases, there will be an increase of the hypercalcemia. CAA ion in the body increases, in which way there is an increased GI absorption. Okay, vitamin D3 production increases because vitamin D3 help in the absorption of the calcium. If there is no active form of vitamin 3, you won't get calcium in the body. So by increasing the vitamin D3 production, active form of with the help of the kidney. We know that in the kidney, especially in the proximal converted tubule, the inactive form of the vitamin D3 is converted into the active form. Okay, 123D co-calciferol. Okay, so active form of the vitamin D3. Now, what happened? The hypercalcemia increases if there is an increased D3 production from the kidney. Okay, and also decrease in the renal clear absorption. From this mechanism in this pathophysiology, the primary hyperparathyroidism work. Now, what are the clinical features you will get in the primary hyperparathyroidism? So these are known as a classic pentad. Okay, so there is an recurrent kidney stones, painful bones. Sometimes there is a formation of the tumors or the cyst in the long bones, which is known as your osteitis fibrosa and the cystica. Okay, this is a pathognomic features, sign in case of advanced primary hyperparathyroidism, formation of the osteitis or the bone tumor in most commonly seen in the radial aspect of the second and the third fingers, okay, phalanges, okay, in the radial aspect of the second and the third phalanges. There is an abdominal growth, there is a pain in the abdomen with constipation, peptic ulcer, and pancreatitis. The cause will be either due to constipation, either there is a formation of too much calcium in the body, which causes ulcerative peptic ulcer, okay, and also there is psychic modes. Psychic modes. So all through 3, 1, 2, 3, and the psychic modes and the fatigue overtones. Okay, it's not written here. And the fatigue overtones all together is known as your pentad. Okay, classical pentad symptom: formation of the kidney stones, painful bones, abdominal growths, psychic modes, and the fatigue overtones. And in the bones, what you will see the osteitis fibrosa cystica. Okay, how will you diagnose the case? With the help of clinical feature, and if you will see that there is an elevated serum calcium level in the body is increases, okay, without the kidney is kidney is working properly, so there may be a no there will be no hypocalcularia, okay, and there is an decreased serum phosphate level in the body. There is a decreased serum phosphate level in the body. Okay, so these are all about your primary hyperparathyroidism. Okay, so ये बहुत important है और ये tumor भी बहुत important है. Okay, so this is all about your primary. Okay, some things I missed. Let's see here. अभी देखते हैं what do you mean by the secondary hyperparathyroidism. So we have done the primary one. Now come to the second. One minute. Let me. Yeah. Secondary hyperparathyroidism. The primary is due to if there is a tumor in the parotid gland. The secondary one is due to the most commonly if there is a chronic renal failure. That means if the kidney is not working properly, then it resulting into the hyperparathyroidism. Okay. So we know that the proximal converted tubule of the kidney help in the conversion of the vitamin active form of the vitamin D2 to the inactive form of the vitamin D to the active form of the vitamin D. Okay. Okay, that is 1,25-dehydroxycocalciferol. Okay, now vitamin D3 help in the absorption of the calcium in the body. Okay, so now suppose if the person is suffering from chronic renal failure or any type of kidney diseases, this mechanism is hampered. So there is no formation of the vitamin D3. The patient is going outside, he's taking vitamins, vitamin D supplement, but still is having the problem. Okay, because this absorption, this conversion mechanism is deranged because of the chronic renal failure. Okay, so obviously there is a less absorption of the calcium. So the patient may suffer from what? The patient may suffer from the hypocalcemia. Okay. Now the body need more and more calcium because he's saying that body is seeing that the body have low calcium ion in the body. So what it will do? It will tell the brain that I am suffering from hypocalcemia. Tell the parathyroid gland to give me more calcium. So what the parathyroid gland will do? It will produce more and more parathyroid hormone. So this is called your secondary hyperparathyroidism. So here, what is the feature? The patient is hypocalcemic. The patient is suffering from the hypocalcemia or the normocalcemia, but all the features of the hyperparathyroidism you will get in the secondary hyperparathyroidism. Okay. So here it is what? Not due to the your any type of the tumor in product in the parathyroid gland. It is mainly due to the defect in the kidney. That is, a patient suffering from, or if there is a GI if the patient is suffering from any type of the GI diseases, which resulting into the decreased absorption of the calcium ion in the body. Okay, so this pathology is very important. Pathophysiology is very important. Okay, so this is all about your primary and the secondary hyperparathyroidism. Now come to the parathyroid carcinoma. It's very important and very easy also. Parathyroid में कोई tumor हुआ and which resulting into the cancer. Okay. So what are the clinical features? Severe hypocalcemic, presence of the severe symptoms. Okay. Severe calcium level in the more than 14 milligram per DL in the body. Okay. Parathyroid hormones level is also increases. Palpable neck mass corresponding to the parathyroid gland. Local invasion is most common. Lymph node metastasis occur in 15% of the cases and distance in the 33% of the presentation. Okay. So इतना ही याद रखना. Okay, the normal value of the the calcium level is 8.5 to 10.2 milligram per DL, and if it is more than 14, then we can suspect it's a feature of a parathyroid cancer. Okay. So this is happening. Okay, now come to the what do you mean by the hungry bone syndrome? Okay, एक minute. This have been done. Yeah. Can you just tell me the answer? What is hungry bone syndrome? A condition high blood calcium after surgery, a condition of the prolonged low blood calcium after the parathyroid and the thyroid surgery, a bone infection, inherited bone disease. So अगर किसी को पता हो तो just tell me the answer in the chat box. बहुत वन वे हो जा रहा है, अब थोड़ा टू वे में करते हैं ताकि आप लोग भी थोड़ा बहुत, अभी MCQs आएंगे. Okay, from the adrenal topic. So if you can tell me the answer. I'm just waiting for एक दो मिनट wait करेंगे and just we will discuss them after that. What you can go to your book, you can type anything and just give me the answer. Okay, it's about Kriti Sharma said A. High condition of the high blood calcium after the surgery. Good, okay. Anybody? Okay, so B is mostly students are saying the B is the answer. Yes. So hungry bone syndrome usually seen after the parathyroid surgery or the thyroid surgery. If the whole thyroid gland is surgically removed, then obviously we know that this is the thyroid gland and the parathyroid gland is embedded within the thyroid gland. Okay, so if there is a full thyroidectomy, then there is an all the features of the hypoparathyroidism we can see. The features of the tetany, that is your low blood calcium level. Okay, so this is known as your hungry bone syndrome. Now see, This is suppose a bone. We know that a bone is made up of the calcium, phosphate. Most of this it's made up of the calcium and the phosphate. Okay. Now, whenever there is an parathyroid, suppose if there is an sudden surgery of the parathyroid gland. Okay. So what happened? There is a sudden increase in the parathyroid hormone in the body. First, इतने सारे accumulated parathyroid hormones थे, for example, it suddenly increases, and then there is a drop of the parathyroid hormone, which causes decrease in the calcium ion in the body. Okay. Now, body has already deficient in the calcium ion, and it does not have the parathyroid gland also to make a hormones which help in the release in the calcium ion. It is a calcium ion. Okay. So if there is a no parathyroid gland, but body needs what? Body needs calcium in the body. Okay. So what it will do? Now this bones are the banker. जैसे बैंक में हम पैसा जमा करते हैं ना, सपोज आपको महीने का 50,000 मिल रहा है, आप 30,000 जमा कर रहे हो और बाकी के 20,000 खर्च कर रहे हो। ठीक है। अचानक से क्या क्या हुआ, आपका जॉब चला गया या बहुत कुछ एक क्राइसिस आ गई। सो व्हाट यू विल डू, you will start to take the money from the bank. So here the calcium and phosphate, for example, the body, these are the bank of the calcium of the phosphate. Suppose ये bone है एक bank जहाँ पर calcium and phosphate जमा होता है। ठीक है। When the body is deficient in the calcium, what the body will do when there is a no parathyroid gland, started to take the ions from this bones. There is huge mechanism, I'm not going to teach it here, but इतना समझ लो, जब बोन से ज्यादा कैल्शियम एंड फॉस्फोरस अगर चाहिए बॉडी को, सो इट स्टार्टेड टू व्हाट, इट टेक द कैल्शियम आयन ओनली, क्योंकि उसको तो कैल्शियम चाहिए, फॉस्फोरस नहीं चाहिए, राइट। तो बॉडी विल टेक द कैल्शियम आयन ओनली, एंड दिस इज नोन एज योर हंग्री बोन सिंड्रोम। ओके, दिस इज कॉल्ड योर हंग्री बोन सिंड्रोम। ठीक है। Let's move to the next part. Okay, so it is a low blood calcium level in the body, typically occurs after surgery to remove the parathyroid or the thyroid gland. Okay, now this has been done. Now the क्या है, let's see the next part. Now tell me, what is the answer of this? Precomocytoma arises from the which cell? Take your time. Yes. So you are like, everybody is right. It is your chromaffin cell. Okay. This can be one of the question. Phecomocytoma. So what is it? Basically, now this is suppose your kidney. Suppose I'm just making it lung. This is kidney. Okay. And this is your adrenal gland. Okay. We know that adrenal gland, there is an adrenal medulla and the adrenal cortex. And this chromaffin cell, it is situated in the adrenal medulla. Okay. When the tumor arises from the chromaffin cell in the adrenal medulla, this tumor is known as your phecomocytoma. Usually, the peak of incidence you will see in the 4th to 5th decade. Okay, the 40 to 50 years of age. ओके, सो इस तरह से याद रखो, फीको, फीकोम्ब्रो, दैट इज क्रोमो, क्रोमैफी, अगर याद नहीं रहता है, सो दिस इज वन ऑफ द न्यूमोनिक फॉर द फीकोमोसाइटोमा। ओके, ओके। So which of the following is not a part of the rule of 10 for the phecomocytoma? Tell me the answer. C, D. Okay, anybody? D, C is D. Okay. Chalo, let's move to the answer. So answer, it occurs in also adult but not a part of the rule. Most of the, in the rule you will see that 10% bilateral, 10% extra adrenal, 10% malignant, 10% familial, 10% children. So इसलिए freakocytoma को we can also say that 10% tumor. So the other name of the freakocytoma is a 10% tumor. Okay. We know that the most common site is an adrenal medulla. The another most common site is your of external adrenal tumor is your organ of Zucker. Okay. And it is situated in the bifurcation of the trachea. Okay, in the bifurcation of the trachea. This is the extra adrenal site. Most common extra adrenal site is organ of Zuckerkund, which is situated in the bifurcation of the trachea. Okay, isko bhi yaad rakhna, which is very important. Okay, next move to the, now tell me the, what is the clinical sign and symptoms of the phecomocytoma? Okay, so everybody is right. The classical triad for the phecocytoma is a headache, sweating, and the palpitation. Okay, the most common, if they ask you the symptom, the most common symptoms will be the headache. Okay, this is the most common symptoms. And if they ask you what is the most common manifestation, the most common manifestation is hypertension. Okay. Whenever there is a phecocytoma, excess of cortisol level in the body, cortisol is stress hormone. Sometimes there is an also there is a cardiac, so there is a palpitation also is another manifestation along with the weight loss. Okay. So let's move to the another. So this is the pneumonic, yaad rakhna, headache, sweating, and the palpitation. Remember, headache, it is the most common symptoms is headache, but most common manifestation, it is hypertension is not a symptom. Okay. Symptoms अगर headache हुआ, sweating हुआ, इस तरह से लग रहा है, palpitations हुआ, so these are the basically symptoms. Okay. Now, best initial test for the phecomocytoma. If the answer is right, the best test for the phecomocytoma is a 24-hour urinary VMA. Okay. So remember, for the screening test, the screening test is most sensitive screening test is also a 24 urinary VMA or the metanephrines. These are the screening test. Most sensitive test, if they will ask you, it is your plasma free metanephrines. Okay, and it is the best diagnostic test also. It is not only the most, sorry, something is written here wrong. Ek thing, one minute, okay. So screening test is your 24 urinary VMA, okay, and the urinary catalomines, okay, not the metanophrines. Here the urinary catecholamines, okay. And this is the best test for the diagnosis, not the best sensitive, most sensitive test. This is the best test will be the plasma-free metanophrines. To locate the tumor, we have to go with the CT or the MRI scan. And for the functional imaging, okay, we can do the MIBG scan. Okay, it is useful to get the extra adrenal tumor for any type of extra adrenal tumor. For the localization, we can give it this CT scan and the MRI. And MRI will be the most investigation of the choice, as it is 100% specific and 95% sensitive. Okay, so most common when CT and MRI is most common to locate the tumor. It is one of the most investigation of the choice will be your MRI. Okay. Now, just tell me this answer. Trichomocytoma is seen in all of the following except. Okay, good. Anybody? So the answer is MEN1. It is seen in all of the following. ये आपको याद रखना पड़ेगा, ठीक है? It is seen in MEN2A and 2B, okay? VHL and the neurofibromatosis, okay? VHL syndrome. Let me see what is the full form of the VHL. Von Hippie-Lippi syndrome. ऐसा ही कुछ है. Let's see, okay? Von Hippel-Leydig diseases, okay, or the Leydig syndrome. Okay, so there is some polycystic diseases, some malignant transformation in the body. Okay, so VHL syndrome. Now, sudden death of the freakocytoma is usually due to the. So I'm completing this only one topic freakocytoma in MCQ based only. And I'm thinking from the next class, I will do this in this way only. So it will help you for the both, okay? आपको MCQ भी मिल जाएगा, plus इसके साथ किस टाइप के like questions के easy भी याद रहेगा. That will be the best way. Okay? You people let me know which is the best way. Okay? So just tell me, sudden death in the freakocytoma is usually due to. Can take your time and do. But we have still 1 more hour left. But before that, I am going to complete this one. Okay, so here the answer will be hypertensive crisis. Freakocytoma, there is an hypertension in the body. Severe if there is an, okay. So answer will be the hypertensive crisis. Yes, everybody is right. It is hypertensive crisis. Now, Zell-Bell pattern is a characteristics of what? What is Zell-Bell pattern? One thing I just wanted to tell you that this is suppose that is kidney, okay, and if there is a tumor, we should not do the biopsy here. Okay, biopsy should always be contraindicated. Why? Due to the it can result in it can precipitate the hypertensive crisis. Okay, so remember this. Biopsy should not biopsy is always contraindicated in the phecocytoma. Okay. Now just tell me this one. Bell-Balain pattern is characterized by Okay, so it is seen in the, obviously, if I'm going with the freakocytoma, the answer will be freakocytoma only. Okay. So this is an MCQ based. So what is Zell-Ballen pattern? It is a basically German word meaning cell balls. Next-like arrangement of the tumor cells seen in freakocytoma and also in the paraganglionoma. ठीक है, इन दोनों को याद रखना. ठीक है. Zell-Bell pattern. Okay. Now come to the another topic. We have completed the freakocytoma. Now go with the neuroblastoma. Can you just tell me what is the neuroblastoma arises from? Yes, the answer, not the answer is D. Neuroblastoma arises from the which of the following? It is from the chromaffin cell of the adrenal medulla. Okay? The most common site, it is arises from the adrenal medulla. So just write it here, the adrenal medulla, then the paravertebral retroperitoneum, okay, paravertebral retroperitoneum, then the posterior mediastinum. So these are the common site, okay. The most common is an adrenal medulla, followed by the paravertebral retroperitoneum, posterior mediastinum, then the pelvis and the cervical area, okay. It is the most common tumor diagnosed in infant of less than 1 year of age. Okay. Most common tumor in the abdominal tumor in the infant who is less than 1 year of age. Okay. So neuroblastoma, acha, common in children not 5 years, it is in the 1 year. Okay. Malignant tumor of the neural, this is malignant tumor of the neural crest, most common in the children, most common intra-abdominal malignancy in the children. Can you tell me what is the most common site of the neuroblastoma again? Common site कौन सा है? Most common site. Just tell me the answer. Yes, the most common site is adrenal medulla. Okay. Now, which of the following tumor shows the Homer right rosette? This in the pathology. So remember this. Homer right rosette is seen in the neuroblastoma. The explanation yaad rakho. It is an arranged in circular fashion. Okay, but without a true limit. It is also seen in the medulloblastoma, primitive neuroendocrine tumor, and the neuroblastoma. Okay, so this is, it is seen in the Homer right rosette. Okay. Now, in neuroblastoma, the most common clinical feature, the patient or the infant will present with your submass in the flank, okay, a fixed lobular mass in the flank, okay. If they come to you, there is some mass in the flank area. It can be painful and it cannot be painless, okay. But most than 70% of the cases, they are all the metastasis has already been taken place. Now, which urinary metabolite is elevated in the neuroblastoma? Okay, so you have to remember this, both the B and the C. Okay, both B and C, urinary metabolite is elevated in the neuroblastoma. Okay, and FHIAA, it is seen in the carcinoid syndrome. Okay, so these are some of the clinical features. You will see this orbital metastasis. You will see when there is a bluish or the blackish discoloration of the eye, which is also known as your raccoon eyes. Okay, when there is an orbital metastasis of the neuroblastoma, the patient will come to you with raccoon eyes, that is a bluish discoloration or the echinosis. Okay. Another thing, there will be some, it's not written here, there will be some cutaneous manifestations such as some, which is also called as a blue muffins. Okay. Blueberry muffinescence. Okay. Remember this. Blueberry muffin listens. Okay. When the stage, they come to the fourth or the fifth stage, there will be blueberry, small bluish type of the lesion seen in all over the body. Also, the patient may suffer from the chronic watery diarrhea, dancing eyes, there is a twitching of the eyes, and also the twitching and the involuntary movement of the feet. Dancing eyes and the dancing feet. So this is known as your oxoclonus myoclonus. Okay, oxoclonus or the and myoclonus. Okay, chronic watery diarrhea due to the excessive secretion of the VIP. Okay, and if you see this one, in the X-ray, there is some sign. This is known as your drooping lily sign. Okay, so drooping lily sign, it seen in the neuroblastoma. Neuroblastoma displaces the kidney inferolaterally, and in the X-ray, it looks like a lily, a flower lily. It gets droops. It is known as your drooping lily sign. Okay, another thing. Let me see. Okay. Okay, so remember this, the features of the chronic watery diarrhea due to the vasoactive intestinal peptide secretion increases, dancing eyes, the dancing feet, and the drooping lily sign in the X-ray. Okay, X-ray will show the drooping lily sign. Okay, and the MRI is superior to that of the CT scan to show the vessels and if there is any spinal cord compression is present there or not. Okay, so I think it's finished. Now, if you have anything missed, just let me know in the chat box. So I was thinking that it will take about 3 hours. So that's finished. This endocrine surgery I finished. In the next class, if possible, I will do some. In the next class, we will do the GIT. We will start with the liver, pancreas, gallbladder, and the whole GIT system. It will take 2 or the 3 classes. Okay, the whole GIT. It's a very vast chapter. Okay, so thank you everyone. Let me know if you have any questions. And if you miss any slide in the, just chat in the, write me in the chat box, okay? So thank you everyone. ओके इसके बाद कोई क्लास है आपका? इसके बाद नेक्स्ट कोई क्लास कितने बजे है? Do you have any class after my class or this is your last class only for today's?
4:30 पे है मैम।
4:30 पे है?
यस मैम।
कौन सा क्लास है 4:30 पे?
मटेरिया।
मैथमेटिक्स का। ओके ठीक है, सो आधा घंटा आप थोड़ा रेस्ट कर लो। ओके, सो थैंक यू एवरीवन, चलो अभी बाय।